ودكتور سالم فات، الباناليست بتوعنا النهارده. دكتور أحمد نجاد إن شاء الله هو اللي هيبقى البريزنتر مع دكتور أحمد خليل. لو تعملوا سكرين شير دلوقتي.
مساء الخير. ازيك يا دكتور احمد، ازيك يا دكتور سامي. احنا ان شاء الله ونجاتي اللي هيقدم النهارده. احنا بلاننج وهيقدم كيس اوف سيستميك فاسكولايتس ويز بولي فاسكولار افكشن كده، و discussing الانفستيجيشنال موداليتيز المختلفه، سواء laboratory او mainly imaging based، والchallenging medical decisions اللي كانت فيها regarding the medications the possible need for interventions. فأنا هسيب نجاتي كده يقدم نفسه، وإن شاء الله يعني تكون ديسكشن سرية ومفيدة لينا كلنا.
Hello everyone. Assalamu alaikum. I'm Ahmed Nagati, a third year resident in cardiology department in Cairo University, Kasraini. At first, I am truly honored to have that opportunity to present this complex vascular case among such a distinguished professor and my colleagues. I will go through that case. The case I'm presenting involves a young patient with life-threatening vascular manifestations and overlapping features of Behçet disease and Hughes-Stevens syndrome, a scenario where every treatment decision could carry significant risk. So I have to choose to present this case under the title of when treatment could kill a vascular dilemma of competing priorities. First, I'll open my camera. Okay, let's start. Our patient is Mr. BG, is a 38-year-old gentleman living Giza from Egypt, married for 1 year, and he has no social habits relevant to his medical condition. Here is the framework we will follow. We will begin by walking through the clinical history, examination findings, and the basic investigations that were performed early on. And after that, I will pause at our first checkpoint to open the floor for discussion around the differential diagnosis. Then again, I will open the discussion after moving through the hospital course, advanced imaging, and therapeutic decisions. We will go for discussion about the management strategies, and we will give a brief literature review about it. So let's start. History of our patient. Over the past 3 months before presentation, the patient has experienced recurrent painful oral and genital ulcers and low-grade intermittent fever, unintentional weight loss exceeding 20 kilogram, progressive fatigue, profound night sweats, and diffuse arthralgia involving multiple joints. In late October 2024, he presented to the rheumatology outpatient clinic at Kasraini Hospital, but he was presented with intermittent high-grade fever, and still he has painful orogenital ulcerations. And also he has bilateral tender erythematous nodules over the anterior tibial surface, suggested for erythema nodosum skin lesion. And productive cough with blood-tinged sputum, left-sided pleuritic chest pain, and progressive fatigue and voice hoarseness. And he was a little bit short and suppressed. Upon reviewing the past medical history, patient in August 2024, while in Saudi Arabia, he presented to the emergency department with acute ischemic chest pain, and he was diagnosed with anterior STEMI, and he underwent for primary BCI. Primary BCI showed a left main coronary artery was free, and LAD was subtotal, occluded with a very large thrombus and a high thrombotic burden, and it was treated with thrombus aspiration and deployed 3 overlapping stents. The LCX and RCA was free. After reviewing the rest of his medical history, he has no other non-chronic illnesses, and his family history was non-contributory, and surgical history was negative.
Ahmed, may I interrupt you? Back to the last slide.
Okay.
Yes,
That one?
38. Yeah, no, the one after. 38 has 38 came with
First one?
MI.
This one?
And Saudi Arabia, MI.
Okay, in Saudi Arabia.
So, yeah.
Okay.
So 38 years old has MI. So is it common? What's the workup done at that time? What was the reason for MI at 38?
Okay, this is a good question, and that he was counseled about that. He has to be counseled with a rheumatologist there because his symptoms, these symptoms was still was begun during the Saudi Arabia in form of genital ulceration and oral ulceration. Then he become more fatigue and the progressive shortness of breath and progressive hoarseness of voice. He didn't follow that. He came to Egypt and he presented after 3 months. He didn't evaluate anything, but he was counseled about that he has to be evaluated for thrombophilia or any other thing. He said also that he was investigated about he did some lab work for thrombophilia and he was negative. But he didn't, he wasn't diagnosed with anything all through these 3 months.
So he wasn't started on immunosuppressive
No,
medication
he didn't take
or anything.
He just was on dual antiplatelet and beta blocker. He didn't take anything regarding his condition as a rheumatological wise. He just take the dual antiplatelet all through these 3 months. Tell presentation with long history of 3 months with orogenital ulceration and progressive fatigue and shortness of breath. But he presented mainly at the end of these 3 months when he started to begin have left-sided pleuritic chest pain and mild shortness of breath and more fatigue and still active ulceration. Okay, is that clear?
Yes, sounds good. Move on.
Okay. This is one of the medical record echocardiographic evaluation post PCI there in Saudi Arabia was revealed that LV ejection fraction was mildly impaired 40% and of normal dimensions and mild regurgitation and regional motion abnormality correlating with the anterior stem. So upon presentation, the physical examination was hemodynamically stable, but he showed that he has fever attacks of about 38 degree. And upon general examination, he has active oral gingival ulceration and active scrotal ulcer and another one healed on the posterior aspect of the scrotum. The rest of general examination and systemic examinations were unremarkable. So clinical summary so far, this patient is a 38-year-old one, no significant past medical history before that 3 months, recent anterior STEMI, he had primary PCI and he has progressive oral genital ulceration, fever, weight loss, night sweat, and other mucocutaneous manifestation as erythema nodosum, progressive hoarseness of voice, and he started to have hemoptysis and pleuritic shortness, pleuritic chest pain. So this is the first checkpoint to take your differential diagnosis. What's your differential at this stage, and what do you think about the key investigations would you prioritize next? Any contribution?
Dr. Sami, you can give us your insights about this patient at this point. Okay, Dr. Salim,
Yeah,
what do you think?
I think yeah, it's a great case. Just knowing the history of the patient and the presentation, young age, I would lean toward inflammatory pericarditis, post-MI complication, but I think there is some sort of inflammatory cascade. Can you go to the prior slide, please?
Okay. This is physical examination one?
Yeah, that one. I mean, and you can tell, nothing really crazy happening cardiac wise after MI. Doesn't look like he's in a shock. Like there's fever, systemic illness. So I think could tell us maybe you have some sort of inflammatory cascade, pericarditis, vasculitis. Very rare people with Behçet or Behçet, they can have some sort of after stent, after MI, the um, if they are immunocompromised, they can have chronic, like stent infection cascade or process. There's a couple of cases that I personally seen with abscess, which is very interesting. But this is a very complicated vasculitis. But I don't think this is maybe. But I widen my differential diagnosis into post-MI complication or inflammatory cascade. So that's what I will vote for.
And you are proceeding with doing what?
What's that?
You will proceed with doing what imaging or what investigational modalities?
Yeah, it's very interesting. I mean, I would like to see an EKG. Probably at that stage, I will go for MRI, stress MRI, to look for ischemia, look for intramyocardial thrombus or embolic manifestation, pericarditis. If we have other stuff like that, but I'm concerned a little bit about inflammatory cascade. Now, MRI will not give you the question about vasculitis, but it can give you a picture about myocarditis. And if the MRI was not convening, then I think I will go for a coronary imaging. You can do a cardiac CT, probably. And in this case, sometimes we order both, depending on what you have. But I will start with stress MRI.
But doctor, if we will talk about saying pathology, how we would explain the other constitutional manifestation apart from fever and fatigue, how you will explain the oral genital ulcerations and some sort of like hoarseness of voice with some differential diagnosis like pericarditis or myocarditis.
So I mean, that tells me you have a lot of again inflammation. The passage itself is not controlled, right? So it's just the systemic illness is going on. And I think I hear the reason I went to the cardiac manifestation, because I think I hear chest pain, right, and have some manifestation of but pericarditis will not be explained by all of that. But fever after MI could be explained by the systemic illness itself or other cardiac manifestation like the pericarditis or the other stuff, you know.
Hello, everyone. My name is Ahmed Abdurrahman. I'm a cardiology fellow in Mount Sinai Medical Center in Miami. Very interesting case. Thank you. I just want to say that apparently there is something autoimmune going on, chronic inflammation going on, and probably predisposed to hypercoagulability in this young age. Honestly, I would put like hypercoagulability as a big thing, and maybe this is all a PE, especially with the fever, the tachycardia, and they are saying that there is some chest pain and probably some hemoptysis. I'm not sure, but also I would put a pulmonary embolism in the differential.
Okay.
So
we need to
I agree with what we said, Dr. Sami and Dr. Abdurrahman, but I don't see any basic stuff, no inflammatory markers, and I think that we are focusing too much on the heart. If it's systemic, we need something systemic. We need to look for the whole vessels, vasculitis everywhere. So I would lean more towards pan scanning more than just focusing on the heart.
Okay, let's go for the basic investigation at first, and we will go step by step. Okay. So the preliminary impression was suggested for clinical features suggested for systemic vasculitis based on multiple criteria. We thought about Behçet disease because we suspected based on oral genital ulceration, erythema nodosum, and the rheumatologist there did the pathology test and it was positive, and the constitutional manifestations and previous thrombotic cardiac event. But let's go for the basic investigations and let's see. This is a laboratory investigations that was revealed mild anemia, leukocytosis, 11, then 17, then 14, and with the left to shaft neutrophilia predominance and left to shaft. We with reactive thrombocytosis and elevated CRP and ESR. And that this inflammatory markers was ameliorated with antibiotic all through the hospital course, as we will see. But still, we have a significantly high CRP and ESR even after the antibiotic course. Other laboratory investigations revealed that normal kidney function and liver function tests pre-diabetic. Hemoglobin A1C was 6.4. Lipid profile that may be contributor to early onset myocardial infarction in a young patient, but he was mildly dyslipidemic. LDL1 was 110. And for sake of infectious workup, we did blood and urine cultures, and they were negative. Other investigation, the next is chest X-ray. Here, this is post-anterior chest X-ray that show normal cardiothoracic ratio, but we can say that there is a large left upper cardiac border that causes shifting to the trachea pushed to the right side here. And also there is a triangular opacity in the mid-left lung zone. No normal costophrenic angle, no effusion. So upon this imaging, we suspected pulmonary infarction, and also we suspected some sort of pulmonary aneurysm or aortic aneurysm, major vascular aneurysm here in light of suspicion of Behçet disease. So we go for CT chest. The value added with the CT chest, that opacity in basal part of upper lobe was more clear that it's an inflammatory process here. There's a tissue breakdown. There's left side triangular pleural-based mass with tissue breakdown. It's the shape of pulmonary infarction. Then we go for the CT pulmonary angiogram in light of suspicion of pulmonary embolism, in light of hypercoagulable state with Behçet disease. So this CTPA showed this lesion. I will pause this film here. This is a main lesion, and there is hypodense filling defect within the left main pulmonary artery extending to its lower lobar division. Is that clear? And we could see that there is a large left paramediastinal lesion showing progressive enhancement in the delayed phase with possible communication with the aortic arch, as we will see, likely vascular in nature. Further imaging was requested by the radiologist. This is the lesion that compresses the left main pulmonary artery and the left main bronchus. Okay. The next thing we did, this is the second phase of the CTPA, delayed phase, that showed that this lesion taking the contrast in the delayed phase with the nearly the arterial phase, when the aorta has filled with the contrast, it takes contrast here, and it causes a compression of the left pulmonary artery, left main pulmonary artery, which is filled by filling defect extending to its lower lobar division. Here it is. So also the radiologist has highlighted that this lesion is also inseparable from the left main pulmonary artery, and it also seen abutting the aortic arch medially and mildly attenuating the left main bronchus itself. So the next step was this, by the way, this CTPA maximum intensity projection reformatted image that help us to show how much the vasculature has been affected by the pulmonary artery filling defect on the left side, especially on the upper left side. Here's the echocardiogram of this patient. Yeah, we will conclude that he has fair contractility according to the biplane Simpson technique. He has about ejection fraction about 48 with LV normal dimension, and with calculations, he has mild mitral regurgitation and tricuspid regurgitation. By calculation, estimated pulmonary systolic pressure was 30, and RV function was normal and with normal RV dimensions. Here's a echocardiogram, and this is the other apical 4 views of his echocardiogram. So next, we requested aortic CT angiography that showed this lesion more highlighted with the contrast in the CT aortography. So here it is. I will activate this laser. Okay, we can see here that lesions that filled with the contrast in the arterial phase and causing the compression of the left main bronchus and also the left main pulmonary artery. This is the reformatted sagittal view that will show that mass here. Here it is, this lesion, and it's also surrounded with marginal thrombus. It carries a marginal thrombus here, and here there is evidence that there is a connection between the distal part of the aortic arch with that filled contrast filled space with the surrounding marginal thrombus. So here it is the radiologist comment about that film. It stated that there is large saccular aneurysmal sac is seen arising from the lateral aspect of distal aortic arch. It measures about 7 and 6 centimeter in maximal axial diameters, and it has a connection with the aortic arch with a narrow neck connection measuring about 4.5 millimeter. It also shows a large eccentric thrombus with maximal thickness about 3.5 centimeter aneurysm, causing, as we said, compression of the left pulmonary artery and linear hypodense filling defect. Also the lung effusion, and here it is another thing. The radiologist observed that there is another smaller saccular aneurysm seen arising from ostial region of the superior mesenteric artery, with a wide neck connecting it to both the superior mesenteric artery and the adjoining aortic segment. It looks like fistulous tract and measuring about 1.5 and 2.5 centimeter at its maximum axial dimensions. So here's we're dealing with multiple vascular affection, multiple aneurysmatic lesions. So we did also CT cerebral angiogram to investigate that patient, but there is no patent sizable aneurysmal changes detected in the CT cerebral angiogram. So as a part of the different imaging modality for such a case, do you think PET-CT will add a value? It's a very rapid question.
May I add a couple of things here? Like, I think if you go back and think a little bit Pichette or Pichette with mass or aneurysm-like vascular structure, right? A couple of things if we're dealing with a PE or pulmonary artery aneurysm, like if we're talking about the vasculature, right? Is it a true aneurysm or a pseudo aneurysm? If you're talking about the PA itself, because looks like you have a big thrombus burden, you have a lot of maybe distant emboli. So I will question that at the beginning, right? And then thinking a little bit also with wider differential diagnosis, right? Infectious process still be a possibility. A lot of Pichette, which is very rare, can have cancers. But you're going to see a lot of lymphadenopathy and mid-design lymphadenopathy, specifically lymphoma can be there. I'm talking about just masses in Pichette, right? And then the last thing, which is very interesting, if we are dealing with just a granuloma with the Pichette and chronic inflammation, because it looks like this guy have a lot of history. So the CT was helpful, but still, I think I need more information. And I think PET-CT, if done right, I think it's going to add a lot of information because I think we you know, the problem if it is done sooner after acute thrombus or like acute PE, you still can have a pickup and you can have a little bit of noise. But I think still it's going to give you a little bit the bigger picture if this mass is avid for the FDG or not. But I will vote yes. So.
Okay, thank you, doctor. And that we did the PET-CT, and as you said, sir, it's so helpful as we say that saccular aneurysm seen arising from inferior aspect of the left wall of aortic arch. But the new thing that it shows that there is mural FDG activity related to its wall of the aneurysm. Well, by the way, is SUV max standard uptake was 5.2, which indicates that there is a moderate intensity of that mural activity. So now we know that this mural activity means that there is active inflammation in the wall of that aneurysm. Also, we can say that there is the second region that CT was revealed in the around superior mesenteric artery, but with no significant FDG activity. And by the way, the hoarseness of voice was revealed in the PET CT that there is hypometabolism of the left vocal cord, which denotes that the patient has left vocal cord paralysis. And rapidly, we did that fiber optic laryngoscopy to confirm that the patient has left vocal cord paralysis, and this is most probably due to left recurrent laryngeal nerve compression by that mass. So rapidly to summarize that investigation we did, there is inflammatory markers that have been rising, significantly elevated, CRP, ACR, normocytic anemia, CTHS showed paramediastinal vascular mass, CTPA showed pulmonary artery filling defect, and CT angiogram, aortic angiogram showed large aortic arch pseudoaneurysm, and the PET-CT showed mural activity. So at this point, what are the most likely diagnoses, and how would you proceed with the management?
So I'm sure that you consulted the rheumatologist. What was their feedback?
Okay, their feedback was that this is a basic activity, and we need to tackle them with immunosuppression. This is the part of the initial management with this dermatologist. They diagnose them with active basic disease with vascular phenotype. Any other contributions?
So
I have a
totally
question.
go ahead.
When the patient got a STEMI, did we have any imaging for the chest, or like, do we know if this aorta is enlarging, like it's progressive disease, or this is the first time we image the aorta?
It's a good point, but actually we have no that imaging data from his medical record. We just have that clinical summary. He was discharged with from Saudi Arabia, but we have no any imaging data from this patient.
Okay.
Okay, let's start. I will talk about the diagnosis.
And Dr. Abdurrahman, do you have any contribution at this point regarding how are you willing to proceed with this patient before Nagati tell us what have he done?
Yes, that's a very good. So usually, if in acute inflammatory state, we don't want to do any intervention. I want everything to settle down first. So I agree with rheumatologist for immunosuppression. I would add anticoagulation for the thrombus and for PE, and I'll reevaluate imaging in few months after that before deciding on any intervention.
Presence of aneurysm that will not prohibit you from adding the anticoagulation.
I don't think so. You have to you balance the benefit risks. I don't think the risk of rupture for this is very high. I think it's the risk of distal embolization is higher than the risk of rupture.
I think Nagati told us the aneurysm measuring was like 7 centimeters.
What did you say?
Size of the aneurysm.
Type of aneurysm?
Size.
Size. Okay, size of aneurysm was very huge. According to literature review, there is nothing.
This patient.
It was 7 by and 6 centimeter in axial diameters. It was very huge aneurysm.
I totally agree with you. The size is a concern, but again, we are not talking about size of regular aneurysm. This inflammatory aneurysm associated with extensive thrombus and PE. So I think the benefit of anticoagulation are much higher than the risk of rupture.
Okay, but as I will say also, we have to emphasize the nature of this. It's a pseudoaneurysm, not a true aneurysm. It has a very small neck, 4 millimeter, with very huge size. So it's with this imaging modality, we can say that it's a pseudoaneurysm. So I think the anticoagulation will differ from if it's a true aneurysm or not. Do you think that?
Can you repeat the question slowly?
I would like to ask if anticoagulation decision will differ if this patient has a pseudoaneurysm or a true aneurysm. I think this is a pseudoaneurysm, not a true aneurysm, because it has a very narrow neck and a well-defined border that's suggested for pseudoaneurysm, as the radiologist has demonstrated.
So just to clarify the difference between the true aneurysm and pseudoaneurysm. True aneurysm is involving all the layers of the vessel. Pseudoaneurysm is involving only one layer. So for pseudoaneurysm, the risk of rupture will be higher than true aneurysm. But I think if we go to image back, I think it's true aneurysm. It's everywhere. What do you think, Sammy?
Yeah, it's very
Okay.
interesting because if it is a true, I mean, I think the size struck me a little bit. If it is above 5.5, that's a problem. Second, if you have connective or inflammatory condition, some people advocate to go for surgical option earlier on. So I think if the radiologist think is a pseudoaneurysm, then you are talking about contained rupture, right? And I think this is with the chronicity, it will need to go for surgery. Now, I think either aneurysm or pseudoaneurysm, to me, probably it's a surgical intervention, and the reason, because if you put this patient on immunosuppressive now, you're going to complicate the surgical outcome and healing and complication for infection if not treated at this point. So I think the pseudoaneurysm gave me a little bit of a goosebump because we are talking about thoracic aorta pseudoaneurysm. But what's is very interesting, he does not have any blood pressure inequality or differential hypertension, or does not have any vascular manifestation of this. And just telling me like maybe all his chest pain that he have, yeah, maybe the PE, but maybe just the compression and the size of the aorta. So yeah, I think the pseudoaneurysm, if it is true, which likely, to me is a surgical option.
Immediate surgical option or after some sort of medical intervention before?
Oh, I will go for surgery.
Okay.
Rheumatologist input will debate, and the reason, if you give people high, like you have to give high dose immunosuppressant for this patient, either steroid plus minus more biological agent, plus treat the vascular if indicated, and the vascular complication. If we're talking about aneurysm, pseudoaneurysm, the size is there. So I think I would be appreciative if I have a CT surgery tell me how we're gonna approach that. But me personally, I think surgery maybe because the treatment of immunosuppressive will not make the aneurysm go away. It will make it not go further. Yeah. So that is why I think surgery may be indicated.
I can tell you we had similar cases. The surgeon will tell you he's not going to intervene in acute infirmity state. That's surgery. No one will touch the patient in acute infirmity state because he cannot do sutures. Everything is like a mesh.
That's a good point. I mean, it's the same thing we're talking about, like LV aneurysm or pseudoaneurysm. Usually they don't like MI. It's different situation, but usually they don't like to because of the healing and stuff. But it's gonna be more problem after you start steroid down the road. Yeah.
Hello everyone. My name is Muntasir. I was a teaching assistant of cardiology at Ain Shams University, and I'm currently second-year resident, almost third-year resident at DMC Detroit, Michigan. I would like to share my experience in management of these patients at Ain Shams University, if we do have enough time and panelists don't mind. So for anticoagulation, I know there is a lot of controversy in literature about this point, but in Ain Shams University, we don't anticoagulate due to high risk of pseudoaneurysm rupture, as long as the patient is hemodynamically stable. For the other question, do this patient need intervention? I would say yes, this patient needs intervention, but the more important question, what is the perfect time for intervention? The problem in this patient is the inflammation of the vessel wall that makes high risk of recurrence of pseudoaneurysm at the site of surgical anastomosis. Even with endovascular intervention, there is a risk of recurrence at the landing zones of the stent. So as long as there is still inflammation of the vessel wall, what we do in Ain Shams University, we follow up the patient every 3 months with ESR and CRB. And of course, the patient is going to be on immunosuppressive therapy during this period. Once ESR and the CRB back to normal level, we repeat CT to see the size of pseudoaneurysm or the aneurysm, if it's getting larger or even stable in size with no regression. At this point, if ESR CRB is normal, we do PET CT again, pre-intervention, to make sure there is no vessel inflammation. And we prefer in Ain Shams endovascular intervention over surgical intervention in these patients due to high risk of complication with the surgical intervention. Another point I would say is the ideal situation in this patient to follow up with PET CT every 3 to 6 months, not only ESR or CRB as we do at Ain Shams University, but the test is so expensive and most of patients at Ain Shams University cannot afford it. And to do it free, we need to have many approvals. So we do this test just one time after ESR and CRB normalized and just before intervention. I would like to, for investigations, I would like to add, I want to know if we do the autoimmune markers and if we did syphilis test for this patient. And thanks.
No, actually,
Okay,
we didn't. We didn't do that syphilis test. But in
Okay,
the
I think we had a lot of opinions, and it definitely takes a huge number of patients to have a protocol for management, as you said, Dr. Montasser. So, starting from me, let's proceed with what Nagati have done.
Okay. At first, I'd like to say that we will talk about the first question, the most likely diagnosis. I will separate these in 3 points. Let's discuss 3 points. Hughes-Stevens syndrome versus vessel disease with pulmonary artery involvement, and they are the same or not. Pulmonary artery thromboembolism versus thrombosis in situ, and pattern of arterial involvement. Is that aneurysm or pseudoaneurysm? To discuss that, we have to refer for 3 important papers published by Dr. Yasser Ahmed, one of the Egyptian rheumatologists, and other co-authors, that collaborative work with what's identified Hughes-Stevens syndrome international study group, and they succeeded to define Hughes-Stevens syndrome and what is it. So this is a paper published about 57 cases of Hughes-Stevens syndrome, and another one about 8 cases. It's a systemic disease characterized by widespread vascular thrombosis and pulmonary vasculitis. Classic features of Hughes-Stevens syndrome include recurrent unexplained DVT or thrombophlebitis, venous or arterial thrombosis with or without aneurysm formation, and pulmonary artery aneurysm with in situ thrombosis. So the diagnosis in previous reports was based on the presence of typical disease features, including widespread vascular occlusive events, and normal coagulation profiles, and CTPA signs of pulmonary artery aneurysm with or without adherent intra-aneurysmal in situ thrombosis or aneurysmal wall enhancement. That's equal to the PET-CT mural activity, post contrast CTPA wall enhancement. So this paper rose a concern about is the Hughes-Stevens syndrome versus patient with pulmonary artery involvement, is that the same or thing or not? This paper is a great paper published in 2024, identified 58 cases diagnosed already with the Hughes-Stevens syndrome from literature review, and they are compared head-to-head with population from a Turkish tertiary center diagnosed with Behçet disease with pulmonary artery involvement. They conclude a very important thing that they are the same. They are comparable with regard to several demographics and the clinical and the histopathological features. And to conclude, they concluded that occurrence of pulmonary artery aneurysm and simultaneously presence of other systemic thrombosis represent a nearly unique manifestation of vascular phenotype of the Behçet disease. On the other hand, the same combination of features was also coined earlier as a Hughes-Stevens syndrome, but they are the same. And this study revealed that histopathological findings from some cases that taken autopsy, the same histopathological finding was seen. Furthermore, the term Hughes-Stevens syndrome don't cover isolated pulmonary artery thrombosis, which could be a precursor of pulmonary artery aneurysm in the pathogenesis, as this paper said. So this creates an ambiguity in our understanding of the pathogenesis and separate the two entities, and they are the same. So, but they found a very important thing, that patients with diagnosis of Hughes-Stevens syndrome were more likely to be treated with anticoagulant, as they presumed that they are not in active vasculitic process. And they were less likely to receive immunosuppressive treatment, which this is not the case, and they are the same process between them. Hughes-Stevens syndrome is an preliminary case of the Behçet, and some cases of Hughes-Stevens syndrome developed other mucocutaneous manifestation and the full established diagnosis of Behçet disease. There is another important paper here that talk about which type of pulmonary artery involvement. After seeing that basic and the histopathological view of this paper is very important, because it highlighted a very important point, that how the affection of pulmonary artery will be seen upon the imaging by the CT angiogram. They stated that there is different 6 category or types of the affection of the pulmonary artery in the Behçet disease with pulmonary artery involvement. One of them, adherent intra-aneurysmal in situ thrombosis, and others full established stable pulmonary artery aneurysm or unstable if it's leaking. Other thing, pulmonary artery pseudoaneurysm, and if it's leaking, it's unstable or enlarging in size. And other thing, intracardiac thrombosis. So we have to deal with these different types of the affection of the pulmonary artery with the cases of Behçet disease. The other thing is in situ arterial pulmonary arterial thrombosis. Is that in situ formed or thromboembolism? Their work stated that intraaneurysmal thrombi in patients with Hughes-Stevens syndrome evolved in situ due to underlying arterial wall vasculitis and activation of the coagulation cascade. This is an important thing, because if it untreated, this may lead to penetration of the intraluminal thrombus through the inflamed aneurysmal wall and extension of the inflammatory process with the adjacent structures, one of them the bronchus, and many cases has a bad outcome due to suffocative hemoptysis and after formation of pulmonary artery pseudoaneurysm. So our hospital course was concluded in 3 points. Chest infection was treated with antibiotics and followed the temperature and the inflammatory markers. Behçet disease activity after rheumatology consultation, he was given Solmedrol 1 gram IV per day for 3 doses, then cyclophosphamide IV every 3 weeks for 6 doses. And he was planned for follow-up visit after 6 weeks. 6 months. Okay. And pulmonary thrombosis in situ was anticoagulation therapy was deferred because the high risk of the rupture, and he was discharged home after a period of close observation of hemodynamic profile and respiratory condition. After 6 months, we did a follow-up aortic CT angiogram and CTP. Here we can see that it is the pre-contrast imaging, and this is the CT angiogram after contrast. As we see, there is still a well-defined aneurysm, nearly measured about the same dimensions, 7 and 8 in the maximum axial dimensions. Also, it's inseparable from the pulmonary artery, and the central filling defect in the pulmonary artery was still there, and it was bilateral. It extended to the right pulmonary artery, causing a saddle filling defect in both right and left pulmonary artery. So we conclude that there is nothing occur with the 6 months of immunosuppression and with the cyclophosphamide and the prednisone the maintenance therapy. And we also did these pictures of the CT angiogram, aortic angiogram, and we also did a follow-up CTBA that showed clearly that the filling defect is still there. Right, is that? And it extending here in the proximal part of the right pulmonary artery also. This is so
you maybe control the inflammation a little bit, but you did not control the coagulation burden, right?
yes, but as we will see when the literature review, there is some cases that totally resolved with just immunosuppression. This is reported in the literature review, as we will see, due to the risk of the intervention.
Just to make sure that we are all on the same page, so you were trying to tell us that there was no difference between PACET and FUJI7 in the literature. It's just an assumed difference, but likely they are the same disease with the same pathology, and that in our patient, when we our strategy was just immunosuppression without anticoagulation, we had a stationary course, or we had a progression of the disease. We had a stationary aneurysm, but a progression of the thrombosis in the pulmonary vessel, right?
Yes.
Okay.
There it is. And this is a current medication the patient take aspirin and clopidogrel for the ischemic event, and pantoprazole, ramipril, and bisoprolol, prednisolone 20 milligram, and cyclophosphamide every 3 weeks. To sum up, the patient has completed 6 cycles of cyclophosphamide. Inflammatory markers improved. Aortic pseudoaneurysm has the same findings. Pulmonary artery thrombosis has the same finding, and he remains off anticoagulation. Would you continue same management? And is there a rule for intervention at this point or not? Any contribution from the floor?
Dr. Sami and Dr. Salim, you think that Dr. Salim, you wanted to go for anticoagulation from the start?
I think Dr. Badr, he said that he will go for immunosuppression at first, then he will see.
So
now we have this patient after 6 months.
Yes, now I would consult surgery first, see if they came for surgery for removal of this pseudoaneurysm, and after that we'll make a decision. But I will get surgery involved right now.
At this phase?
Yes.
But I would agree with that too. I mean, and I think when you look backward, right, is a surgery is an urgent, like, is it a stage surgical planning from the beginning, right? Are we going to involve the CT surgery now and to come with all this hot mess and do the surgery? Probably not. But I think now maybe we are in a better position. Okay, we need to do something about it. They may refuse; they usually do. But I think we need to have a little bit of surgical input.
Okay, let's discuss the literature review about that. There are 3 points. First, medical management. Then we will talk about the endovascular intervention. Then we will talk about the surgery. Medical management in form of 3 points: immunosuppressives, biologic therapies, and anticoagulants. Literature says that in the papers we have stated before about 50 cases of Hughes-Stevens syndrome, Imad et al. This was significantly less common in patients that were treated with oral corticosteroids. or pulse cyclophosphamide or azathioprine or combined immunosuppression. That's a statistically significant finding in that paper. Other paper demonstrated that standalone medical therapy was effective in one paper to completely resolve the in situ thrombosis without any therapy of anticoagulation. Efficacy evidenced by follow-up CT angiogram that revealed that all of the in situ thrombosis has gone with just immunosuppression. And another paper says that standalone medical therapy led to complete resolution of an aortic arch pseudoaneurysm itself. And that also, this paper has a case report of favorable evolution of a pseudoaneurysm in a Chinese patient, illustrated a case with aortic arch pseudoaneurysm, and it was smaller. It was about 2 and 3 centimeter in axial diameters. And patient was medically managed just by bolus of sulmidrol and cyclophosphamide. And after 4 weeks, he added azathioprine and the colchicine. And the patient pseudoaneurysm was resolved completely after the follow-up CT angiogram. Till now, the EULAR recommendation highlighted the management of the Behçet disease-related pulmonary vasculitis, that we need the immunosuppression, and it recommended against the anticoagulation in that phase. And it recommended with the aorta and the peripheral arterial aneurysm to give firstly the immunosuppression before any surgical option. They stated that treatment with steroids and other immunosuppression will give a better outcome in these cases. Then the biological treatment, there is a multi-center study demonstrated that efficacy of tumor necrosis factor alpha antagonist in about 18 refractory Behçet disease patients that was treated with basic immunosuppression with steroids and other immunosuppression at first, and they have no better outcome. Then they gave the tumor necrosis factor alpha antagonist, and the results of this study demonstrates that vascular remission was achieved in about 16 out of 18 patients. And in form of what? In form of size of that aneurysm was diminished with and there is no bad outcome during the follow-up in this study. But it relatively carry a small follow-up duration. It's about a 1.5 year of follow-up, just 1.5 year. Other study demonstrated the efficacy of interleukin-6 inhibitors. The same caveat of this study, the short follow-up duration and just positive for nothing bad outcome during that short period of follow-up time, but it didn't completely resolve the pseudoaneurysm. Regarding anticoagulation, in the EULAR recommendation, as we said, even acute DVT patient, I know that our patient has no acute DVT, but this recommendation will apply that acute DVT in Behçet disease patient also treated with steroids and immunosuppressive, and there is no rule for the anticoagulation in these patients. And in refractory venous thrombosis, monoclonal tumor necrosis factor antibodies could be considered, and anticoagulant may be added even only if coexistent pulmonary artery aneurysm are ruled out. So they talk about there is no safety about the anticoagulation with pulmonary artery or aortic aneurysms. However, there is another 2 studies that illustrated some safety for this anticoagulation. First one tested the anticoagulation in 7 out of 8 cases of Hughes-Steuben syndrome, and it presumed to be safe. The 8th case aborted the anticoagulation because due to a patient has already have fatal hemoptysis. The another one, there's no significant association were observed between fatal outcome and anticoagulation therapy. This was about 42 cases of Hughes-Steuben syndrome and published by Dr. Imad also. So there's controversy about the safety of the anticoagulation. There are recommendations against that, and there is 2 papers, but with the small sample size, recommend that there's safety about anticoagulation in this such case. About endovascular and surgical management, we should to focus on current vascular lesion. Is it aorta or pulmonary? Is it pseudo-aneurysm or aneurysm, true aneurysm? And also, as Doctor said, the progression on the CT follow-up, if the size increasing or not. And CTPA also play an important role in the follow-up of patient with Hughes-Stevens syndrome to evaluate the pulmonary artery aneurysm regression or progression. Endovascular interventions like coil embolization, there is a literature review about that, and they found that coil embolization may be indicated on an urgent basis without waiting for the effect of immunomodulators if we have leaking pulmonary artery aneurysm, as we demonstrated in previously in paper with 6 different types of pulmonary artery affection. Those with leaking and unstable aneurysm, we can go for coil embolization, endovascular intervention, not surgery, with some safety. Those that underwent pulmonary artery embolization and coiling were also less likely to have fatal outcomes, according to this paper, and but it's not statistically significant finding. But in another one with Dr. Imad, in about 42 cases with Hughes-Stevens syndrome, they found that there is significant positive association between fatal outcomes as a dependent variable and ruptured pulmonary artery aneurysm. Those patients with unstable pulmonary artery aneurysm and treated with endovascular intervention was statistically significant for better outcome with this endovascular intervention. Another study states that significant negative association were observed between fatal outcome versus treatment with combined immunomodulators. There is negative association between the fatal outcome versus pulmonary artery coil embolization and combined immunomodulators. Both have better outcome if we have did this. But our case mainly the aneurysm in the aorta, not the pulmonary artery. The literature review about that, we found 2 studies. A study of more than 20 aortic vascular Behçet disease cases. This study concludes that preoperative ESR below than 16 and the preoperative steroid use more than 11 days at least, and the preoperative immunosuppressant use for at least 2 weeks were found to have predictive value for more postoperative adverse events. If we wait till the resolution of the inflammation and we used that immunosuppression for adequate time, at least 2 weeks, we will have a better outcome. And this is that illustrated a very important thing, that we have to treat the inflammation at first, as Dr. Badr have said before. Another study demonstrated that patient that was treated with endovascular intervention but without sufficient time of or sufficient duration of immunosuppression perioperatively, he developed a recurrent aortic aneurysm, and he has a fatal outcome due to rupture of this recurrent aortic aneurysm. So in conclusion, we suggest that surgical operations, including endovascular treatment, should be avoided in treating aneurysms of vascular disease, except for patients under life-threatening condition. When scheduling for an operation, we should avoid the active phase of Behçet disease and to determine to operate when ESR and CRP are normal. Postoperative steroids and immunosuppressive drugs need to be continuously used, and patients should continuously undergo long-term observation and follow-up. That's all. And this is our summary and key takeaways, that this rare life-threatening vascular involvement presented with both arterial aneurysm and thrombosis, importance of aggressive immunosuppression to control arterial inflammation. Anticoagulation remain controversial, but we require individualized risk-benefit assessment. Vascular bacillus versus Hughes-Steuben syndrome overlap, and it's the same nearly. And last thing, long-term close imaging surveillance is mandatory. The floor is open for discussion.
Thank you very much. I think it is very interesting and very complicated, very complex case. And you guys, Dr. Ahmed Nagat and Dr. Ahmed Khalil, they did fantastic job in presenting this case. I have a couple of comments only. So every case is different based on the patient. This is a very young patient. So I wouldn't consider for very young patients endovascular intervention, because if you compare endovascular versus open surgical repair, the endovascular is associated with recurrent reintervention. And for a patient is 30 years old, you don't want to bring him several times for reintervention. You need to do the job from first time. I think the surgery will do. If it's old lady or old patient, I will consider endovascular. But for young patient, I will go for surgery first. Second, for anticoagulation. So this patient already had anticoagulation. He had STEMI, had massive amount of blood thinner, and nothing happened. So I don't think the risk for anticoagulation for fatal outcomes with anticoagulation is very high. But excellent job. I'm so proud of you, both of you, and thank you very much for sharing this very interesting case with us.
Thank you, Dr.
I think thank you, Nagati. Actually, this is a summation of the work of the people who are working at Qasr Al Aini, not someone who did it by himself, one or two persons. Second thing, this is what always emerges when we deal with this relatively rare case. This is not heart failure where there are a lot of patients. We all see them on daily basis. We have a lot of data from randomized trials tell us what to do. So there will be much less disagreement. But when it comes to these cases, there is always disagreement, and there is always should be individualization and personalization of the decisions. And we have seen also patients with RVs thrombi, and we usually anticoagulate these patients. Then it emerges this dilemma when they have pulmonary aneurysm along with the RVs thrombi. Should we anticoagulate? Should we just go for immunosuppressive? And there's also this conflict about those patients with sizable RVs thrombi. Should they go for surgery? But what about the risk of recurrence? So it needs a lot of experience, and that we have seen, like Dr. Montasser was trying to tell us about the protocol at Ain Shams, because they are likely to have seen a lot of patients that allowed them to make a protocol. So there should be individualization, expert opinion should be put into consideration, and I think there is no definite right or wrong in such cases. So for this patient, you will be willing to go for surgery, Dr. Sam, and you will be willing to do the same, Dr. Sam. Dr. Sami. I don't hear you. Okay, we lost him. But Dr. Salim, when you think about the age, I think you are talking from a different pathogenesis. When we talk about the age into vascular surgical, we're talking mainly about the patient with a different mechanism of aneurysm. So for this patient with a high risk of recurrence of the inflammation and the aneurysm, still you will be going to go for surgery with the risk of redo surgery.
Yes, I would. My first choice would be surgery, because again, if you control the inflammation, so the risk will be the same. So I think a re-intervention with endovascular will be much higher than with the surgery. This is my opinion.
Okay.
So did you guys consult surgery or no?
Yes, we did. We did.
What
The
did
patient
they
now
say?
is currently referred to the senior cardiovascular surgeon.
Excellent job.
Dr. Montasser, do you have anything to add?
No, thank you so much for this interesting case.
Okay, thank you for your valuable input.
Thank you, Dr.
Nagati, you have concluded?
Okay, as we said, we have different options, but we can conclude that surgical option versus endovascular treatment. But as Dr. Prader said, the patient actually has referred to the cardiovascular surgeon.
Okay.
And
I think
as
we had
Dr. Mu'tasim said, the plan also to repeat again the PET-CT.
perfect. Okay, I think thank you for this perfect presentation, and we hope that we can follow up this patient maybe like after 1 year. If
Thank
you are
you.
still here or the patient is still here.
Thank you.
Do you want to add anything, Dr. Salim? Anyone from the audience would like to add anything?
No, thank you very much. Thank you. We appreciate your efforts, guys.
Thank you, Dr.
Thank you. Okay, I think we are done for today. Thank you very much all.